Very good afternoon to all. Index case is 65-year female. She has TVD with unstable angina with minor dysfunction. She also had left-sided TIA 3 months back, and on evaluation, she had found 95% stenosis in right internal carotid with mild disease on left. So there are multiple questions which has to be answered before treating this patient, like whether she required coronary intervention or not, whether she will require carotid intervention or not, and if required, what will be the timing and the sequence of the intervention. As you all know, I am a surgeon. There is always a bias treating this patient. However, in these presentations, I would try to justify what is the best option available for her by more focusing on facts as compared to beliefs. I think this patient will definitely require CABG, and which has been supported by many guidelines. Even recent AHA has supported this. Before going further, just small, very quick recap of carotid artery stenosis. It can be defined as symptomatic and asymptomatic, depending upon presence of symptoms. If the symptoms are within 6 months, then it is called as symptomatic. If the patient has symptoms of more than 6 months, then it is called as asymptomatic. Another classification is presence of a stenosis, degree of stenosis of internal extracranial internal carotid artery. Depending upon that, it can be classified as mild, moderate, severe, or complete. Why it is important to know for us? As you know, this patient will require CABG. So a very beautiful article by Nailo says that risk of stroke after CABG is proportional to a degree of a stenosis. So if the patient has more stenosis, she will have a higher risk. And it is important to note that around 23% of patients will die. So not intervening carotid will lead to high risk of morbidity and mortality in this particular patient. Even recent guideline says that a patient, symptomatic patient with symptoms, with a 50 to 90% of degree of stenosis ICA should intervene. Carotid has to be intervened, but they have told that method, timing, and the sequence will depend upon the patient's conditions. So, what intervention available for carotid we have? As you all know, the aneurysmectomy, which is the oldest and most commonly performed procedure worldwide, and second is stenting, which is gained popularity nowadays. When talk about isolated carotid artery stenosis, we have multiple RCTs comparing both of these. They are mainly industry-driven or a controlled RCTs. These are some industry-driven carotid trials, out of which Sapphire was the most important one. It has shown a non-inferior of stenting over to carotid endarterectomy in a patient of high risk. However, there are many caveats. One, it is heavily industry influence. Second, there is some amount of selection bias because out of 700, only 334 were included. Third, 25 patients on both arms were died. And there is also a controversy about definition of MI, leading to more cases in both arms. There are other randomized control trials like ICSS, EVA, 3S, A1 space. They have all shown a CA is better as compared to stenting. The most important, even ICSS has shown that around 50% of the patients which are undergoing CS has having new MRI finding compared to aneurysmectomy. The most important and most talk about this is CREST trial. Even CREST trial has shown that stenting has little amount of increased pre-procedural death as well as stroke where compared to aneurysmectomy, especially in a patients of more than 70 years. They have also published a long-term data of 10 years. In this data, they have shown long-term endarterectomy versus stenting is both are equivalent results. However, when we do a subgroup analysis, you can see the risk of stroke is more in a patients with more than 65 age, symptomatic, and a female patients. So our index case is female of more 65 year with symptomatic. So in this case, aneurysmectomy will definitely give a better short-term as well as a long-term results. These are the recent meta-analysis which summarize all these studies and which have shown similar results. Based on these findings, These are the recommendation by European, which shows that aneurysm is a class 1 indication with level of recommendation of A. There is also a role of stenting, but they have given a class 2A class with a level of evidence of A. What are the indications? When a patient is very high risk of because of cardiac or pulmonary disease, or more age is more than 80 years, in a recurrent disease, patient having previous radiations, or a patient having bilateral disease. Even a recent stroke guideline have confirmed that aneurysm remains a class 1 indication with a level of evidence of A. However, if the patient needed both, then what will be the timing and sequence? It will depend upon three important questions. That one, which vascular bed is more symptomatic? What is the anatomy? And what are the individual risk factors? Depending upon that, sequence will be concomitant, that is performing the procedure simultaneously. Stage, that means carotid intervention followed by coronary interventions, or it is a reverse stage. That means a coronary first followed by a carotid second. So what are the general indication for concurrent approach? If the patient is symptomatic for both, severely symptomatic for both vascular bed, then that patient will require intervention of both. Like in a cardiac, if the patient has unstable angina, just like our index case, or severe LMC disease, or TVD with liver LV dysfunction, or critical LED lesion. Along with if patient had symptomatic carotid stroke or anything with a stenosis of more than 50 degree, or asymptomatic with high risk carotid, that is bilateral involvement of more than 80%, or a one side total occlusion and a significant lesion on one side, then this patient is more suitable for concurrent approach. If the patient has more severe symptom for carotid, then it is better to have a stage approach. Or if the patient has more symptom on coronaries, then it is better to have a reverse stage approach. So our index case has a symptomatic severe carotid stenosis with unstable angina. So she is best suited with combined approach. But there is still a choice, there is still a lack of data when a patient undergoing CABG. So what intervention is we have to choose between stenting or carotid artery in a patient undergoing CABG? There are no RCTs available. The data available are prospective observation studies, or most of the time it is retrospective. There is also heterogeneity of the population. Like some, they have included symptomatic as well asymptomatic patients for carotid, as well as they have included patients with stable angina, unstable angina. Also, the timing of intervention is different. Like they have mostly compared a concurrent aneurysm versus a stage stenting, or they have compared a concurrent stenting or aneurysm versus a stage aneurysm or a stenting. In this beautiful article, which is I got largest of patient, or 22,000 patients by Fieldman et al., published in 2017, shows that aneurysm remains a most frequently performed procedure, but it has a least stroke rate, but it has a higher mortality rate compared to stage stenting. A recent meta-analysis also confirmed the same finding. It has shown that the risk of death is more when you do a concurrent aneurysm with CABG compared to stage. Also, but in this meta-analysis, they have also do subgroup analysis, and if they remove the patients with Feldman, they have shown that the mortality benefit of stent was vain. Whatever the benefit, when we see these results, it has been shown that we perform concurrent aneurysm or stenting, the risk of death or stroke will be higher, like around 6 to 10% when we do both. Why? Because in these studies, most of the patients underwent on-pump CVG. There are no data of, they have very less amount of the patients are underwent off-pump CVG. Based on these findings, the European have given a recommendation of aneurysm along with CABG in a symptomatic patient with a high degree of stenosis with a class of 2A and a level of evidence of B. They have not talked about stenting yet here. But important to note in India that we are routinely performing off-pump CABGs, and there are multiple data are available which shows when we do concurrent angiotectomy with optimum CABG, the stroke and death rate comes to less than 2% or equivalent to 2%. That is a patient, that is the same as a patient undergoing CABG without any stenosis of the carotid. So my preferred approach in this patient will be angiotectomy and off-pump CABG simultaneously. So my take-home message is, still there is a scarcity of data. Current evidence still leans towards the angiotectomy. Combine in this particular patient, combined angiotectomy and off-pump is preferable to have better short as well long-term outcome, least MI, least death, and least stroke rate. There is still role of stenting in this patient if it is not a candidate of angiotectomy. Thank you.